So we're going to continue with the Mrcp basis consultation station cases. And today I'm going to talk a bit about Myasthenia gravis. And this case is very common, and you may come across this case in your consultation station as well as in your neurology station. So let's start our presentation. So this is our case scenario. A 28-year-old woman presents to her GP with a 6-month history of fluctuating double vision, especially towards the end of the day. She also mentions that she has difficulty keeping her eyes open after reading for long periods. Over the past 2 months, she has also noticed difficulty in swallowing and occasional choking, especially when drinking fluids. So as I told you before also, whenever you came across the statement, just look for the buzzwords. So here are the buzzwords are fluctuating double vision, which get worse at end of the day. And she has difficulty keeping her eyes open when she's reading for long periods, and there is difficulty in swallowing. So already you know there is something wrong with your neuromuscular junction, or you're thinking about Myasthenia gravis, and that one should be on the top of the list of the differential diagnosis. Okay, let's move on and talk a bit about the history. So once you have read the statement, just brainstorm, think about all the differential diagnoses, compose yourself and take all the relevant history. So again, the history, you are going to introduce yourself and take the consent of the history from the patient. So presenting complaint, then you'll ask, can you tell me more about the eye symptoms you have been experiencing? And when did you first notice the double vision? And we also want to ask about progression. Has it been getting worse? We'll talk in detail about the symptoms which the patient has presented. About the duration, how long does the double vision last? Does it improve with rest? Any aggravating factors? Does anything make it worse, like reading or watching television? And relieving factors, does anything make it better, like closing one eye? We're going to ask about the associated symptoms, like from the eyes. Have you noticed any drooping of one or both eyelids, and does this get worse as the day goes on? We'll also ask about swallowing. Have you had any difficulty swallowing? Is it more with liquids or solids? Speech. Have you mentioned any changes in your voice, especially after talking for extended periods? Breathing. Have you felt short of breath or had difficulty breathing? And then we're going to ask about generalized weakness. Have you experienced any weakness in your arms or legs? So these are all about the presenting complaint. Now you already have some differential diagnosis in your mind. So when there are many differential diagnoses. I'll talk about it a bit later, but considering the history, you'll be thinking about it can be like demyelinating multiple sclerosis. So you can ask the patient any past history of any sudden loss of vision, numbness, tingling, or problem with balance. We'll also be asking some questions about, we were thinking about Lambert-Eaton myasthenic syndrome. So have you had any problem with dry mouth or constipation, or do your symptoms get better the more you use the muscles? So you know that Lambert-Eaton is a bit different from the Myasthenia gravis, and symptoms get better with the exercise. About the brainstem lesions, we'll be thinking about brainstem lesions as well. So we'll ask about any problem with the dizziness, hearing loss, or facial numbness, and Graves' disease also. So we're going to ask about any changes in the patient weight and heat intolerance or tremors. So these are the major 4 differential diagnoses when the patient come across with the any eye symptoms like diplopia. Then you will ask these questions, and when you are systematic, like you asking about all about the presenting complaint, and then differentiating your diagnosis, the examiner knows that you have good knowledge, and by asking question how to differentiate between these conditions. So we're going to also ask about the risk factors, like autoimmune. Do you have any other conditions where your immune system attacks your body, or do you take any medication that might affect your immune system? You can rephrase it actually, but have to ask about any autoimmune conditions in the past. Thymoma, have you ever told you have a tumor or mass in the chest, or previously any surgery done or anything, past medical history, any previous medical condition, surgery, medications, are you currently taking any medications including over-the-counter drugs, and finally the family history. Does anyone in your family have similar symptoms or any autoimmune conditions? I have not mentioned it, but just add on the social history as well and ask about especially about the alcohol and smoking and job, and where and how about the family, and is everything good in the family? That one could be asked. So once you've taken the history, then you'll move on to the neurological examination. So what neurological examination should be done in suspected myasthenia gravis? Here you need to be very systematic, because the time is very short. It's not possible to do whole physical examination from head to toe. So first of all, you do the general inspection. So observe the patient from the end of the bed and note any obvious ptosis. Check if there is any mediastinal mass on the chest X-ray available, including indicating a thymoma. So sometimes when you are taking the history, you may ask the patient any investigations done or any medicines which patient taking. So sometimes the patient have a record. They will show you what medicines they are taking, or what tests were done, including chest X-ray, CT scan, or MRI, whatever. If in that case, then you have an additional clue. Then, very important, you have to do the cranial nerve examination. So we're going to check the eye movements. That will check our cranial nerve 3rd, 4th, and 6th. So we're looking for any fatigable diplopia. So ask the patient to follow your fingers in the horizontal plane and then vertical plane. Keep them moving their eyes for a minute or so to see if their diplopia worsens with sustained effort. Then we want to check the 7th nerve, like facial strength. We ask the patient to show their teeth, frown, blow out their cheeks, close their eyes tightly. So you are checking the strength of the facial muscles. Then we will be checking for the speech. So mainly we're checking the cranial nerve 10 and 12. So listen to the quality of the speech. Ask them to count from 1 to 100 or recite days of the week repeatedly to check for any fatigable dysarthria. Now we have a shortage of time, so maybe this one you can skip, or maybe just keep it till counting only. Swallowing, ask if any difficulty swallowing or if it gets worse with repeated swallowing. Then we'll proceed to the limb examination. So be very systematic. First we do the general inspection, move on to the cranial nerve examination. So it's mainly on the face, and then you move to the limb examination. So power, check for the proximal muscle weakness. Ask the patient to raise their arm above their head and keep them there. Look for any fatigable weakness. And similarly, this test you can do with the leg raise to test the hip flexor strength. And check for any reflexes in sensation. Usually, we expect it to be normal in myasthenia gravis, but worth checking to exclude the other diagnosis. Then, once you've done this limb examination, then we can do the fatigue test. That is actually sustained gaze. Ask the patient to look upward for 2 to 3 minutes. A positive result is a development or worsening of ptosis. So this one, actually, fatigue test you can do while you're doing the cranial nerve examination. You just have to ask them to look upward for 2 to 3 minutes. And similarly, another fatigue test is arm raise test. So ask the patient to stretch their arms out in front of them and keep them elevated. So a positive result is actually a gradual descent due to weakness. So, and once you have done this, then briefly you'll just do the respiratory examination. You will ask for, in conclusion, you can say, I want to do the lung function test as well, especially checking for the vital capacity, as the patient may go on to myasthenic crisis, which can affect their breathing. And general examination, especially looking for any mediastinal mass or anything. Although that one only you can see on the, if the patient has any X-ray report or CT scan report, then only you can be sure. So this was all about the examination. So just follow these steps and remember, please be systematic. So finally, once you've done the examination, okay, then you can this one actually will come in the end while you're doing your presentation, but I'll just edit it here because sometimes this case can appear in your neurology stations. So neurology station, there's no need to take the history. You just have to take consent and do the examination. So this statement I have added for the neurology station. So I would like to complete my examination by checking the vital capacity, reviewing the recent chest X-ray for evidence of a thymoma, and if possible, performing blood tests looking for acetylcholine receptor antibodies. So this is for the short case or neurology stations. Once you've done the examination, then you put this statement that will create a good impression on the examiner. Now, there are many differential diagnoses for this patient who has come with the diplopia or vision disturbances which get worse at the end of the day. So one of it is Lambert-Eaton myasthenic syndrome. So it is another autoimmune condition, and it is usually associated with a malignancy like small cell lung cancer. And it is characterized as weakness, but that weakness improves with activity. So it is opposite of the myasthenia gravis. Here, the autonomic nervous system can also be affected, so leading to symptoms like dry mouth. Another differential diagnosis is botulism. A rare poisoning is caused by toxin, which is caused by Clostridium botulinum bacteria, and it can cause a descending paralysis. Thyroid eye disease can present with eyelid retraction, lid lag, or exophthalmos. However, there is no fatigable diplopia. Brainstem lesions, any tumors, any vascular malformations or other lesions, they might affect the cranial nerve nuclei, so causing some overlapping syndrome. Oculopharyngeal muscular dystrophy, where this will be a genetic condition, so present long history will be very long, where weakness start in the eyelid and throat muscle. Multiple sclerosis, well, this is an autoimmune condition of the central nervous system and can present with a variety of neurological symptoms, some of which might overlap with myasthenia gravis. Drug-induced myasthenia, remember this one very important. Some medications like penicillamine, statin, or neuromuscular blocking agent can also cause myasthenia gravis-like symptoms. Then we have some congenital myasthenic syndromes. These are quite rare hereditary disorder that arise from various genetic mutations. They can mimic myasthenia gravis, but usually present earlier in life. And neuromuscular junction disorders, conditions defined neuromuscular but are not autoimmune nature. Example include certain types of encephalitis. And then we have a Miller-Fisher syndrome, which is a variant of GB syndrome. It presents with ataxia, areflexia, and ophthalmoplegia. And some muscle disorders like polymyositis or dermatomyositis, it can present with muscle weakness, but usually more generalized, is not limited to ocular muscles. And then we have transient ocular myopathies. These can lead to transient diplopia and muscle weakness, but they do not have the fatigable nature of the myasthenia gravis. So important is, I put so many differentials here, but if you can remember the main one, like Lambert-Eaton myasthenic syndrome is very important, botulism is important, thyroid eye disease is important, brainstem lesion is important because this is a serious condition, multiple sclerosis, and drug-induced. If you remember, only 4 or 5 should be enough. Okay, so how will you diagnose the myasthenia? Obviously, you have to take the complete history, do the examination, already had a clue. And then, in additional for your diagnosis, you can do some tests. Like serological tests, we can look for acetylcholine receptor antibodies, and they are present about 85% of myasthenia gravis patients with generalized symptoms and 50% of those with purely ocular symptoms. Then another antibodies is muscle-specific kinase antibodies. Important to check if acetylcholine receptor antibodies are negative, and they represent a subset of myasthenia gravis. We have another antibodies called lipoprotein receptor-related protein 4 antibodies, and another is titin RYR antibodies. This can be seen in some myasthenia gravis patients, especially if other antibodies are negative. So mainly remember acetylcholine receptor antibodies and muscle-specific kinase antibodies. So this was about the serological testing. Then what are the other tests which can do? We can do some electrophysiological tests. By this include repetitive nerve stimulation. So this test actually involves sending the multiple electrical impulses to a nerve and then observing the muscle response. So in myasthenia gravis, the muscle response diminishes with repetitive stimulation. And you can also do the single fiber electromyogram or SFEMG. This is a more sensitive test than this repetitive nerve stimulation. It measures the variation in time it takes for individual muscle fibers to respond to nerve impulse. So increased variability in response time is consistent with the myasthenia gravis. So I repeat again, for the testing, we talked about serological testing, we talk about electrophysiological testing, and then we'll talk a bit about imaging. Chest CT or MRI, this is crucial actually to check for thymoma, given the association between myasthenia gravis and thymomas. Then there is a pharmacological testing called hydrophonium test or tensilon test. It causes rapid but temporary relief of muscle weakness after IV administration of hydrophonium chloride, which is suggestive of myasthenia gravis. But remember that it is not used now, less commonly used today, because we have more specific tests like acetylcholine receptor antibodies and less risky diagnostic tools than this tensilon test. Okay, so remember all these tests: serological tests, electrophysiological tests, and imaging mainly, and you can just mention about the tensilon test. So what about the management of myasthenia gravis patient? What should be your approach? This was all about the investigation. So in the management, we're going to, again, I have divided into different sections. So first of all is we talk about the symptomatic management. By symptomatic management, we have an option of acetylcholine receptor inhibitors, and these drugs like pyridostigmine, they increases the concentration of acetylcholine at the neuromuscular junction by inhibiting its breakdown, and they provide rapid relief of symptoms. However, remember, they do not alter the course of the disease. So the patient should be started on a trial dose and then try to titrate based on symptomatic relief and side effects. And the side effects include abdominal cramps, diarrhea, and excessive salivation. Another group is immunomodulation. Now, immunomodulation, we have corticosteroids. So prednisolone can be used. Idea is to suppress the autoimmune response in myasthenia gravis. Start at a low dose and titrate it based on the response and side effects. Long-term use may necessitate the bone protection and monitoring for other side effects of steroids. Another immunomodulation is another class is immunosuppressive agents. So in patients who are either unresponsive to or they are intolerant to steroids, agents like azathioprine, mycophenolate mofetil, or methotrexate, they can be considered. And regular monitoring is required due to potential side effects, including bone marrow suppression. So remember these two groups. It's always a good idea to remember the management whenever you're trying to memorize the management, divide it into groups. So symptomatic management and immune modulation. So what about the myasthenia crisis? Rapid symptomatic relief for myasthenia crisis, we have option of plasmapheresis, and this involves actually removing antibodies from the blood, and it can provide rapid but temporary relief of symptoms, especially during a myasthenic crisis or in preparation for surgery. IV immunoglobulin, another option. It can also provide quick relief symptoms, but usually reserved for patients who cannot undergo plasmapheresis. Or IV immunoglobulin in some studies is found to be superior to the plasmapheresis. Then this one you must mention in your management plan about the thymectomy, because thymus gland is believed to play a role in the pathogenesis of myasthenia gravis. So surgical removal can be beneficial, especially in patients who have thymoma. So a CT scan of the thorax is essential to evaluate the thymus gland. Even the absence of thymoma, thymectomy might be beneficial for certain myasthenia gravis patients, especially for the younger patients. Monitoring and follow-up. Well, we want to want the patient to visit clinic regularly to monitor the symptoms, side effects of medication, any signs of complications. We want to do the pulmonary function test, especially important if respiratory muscles are involved, or if contemplating a change in immunosuppressive treatment and antibody levels. While they don't always correlate with disease severity, they can sometimes be useful in tracking the disease activity. So these are the three things which we have to do while monitoring and follow-up of the patients. Patient education and support, don't forget it, very, very important. Educate the patient about the importance of medications, adherence, potential side effects, and when to seek urgent care. Discuss the potential triggers for symptomatic symptoms exacerbations, including infections, certain medications like antibiotics and beta blockers, and stress. and recommend the patient to wear a medic alert bracelet indicating their diagnosis of myasthenia gravis, and connect the patient with support groups or any counseling services, especially given the chronic nature of the disease and its impact on the quality of life. We need a multidisciplinary approach for this for the myasthenia gravis. Remember this buzzword, always mention the multidisciplinary approach. So involve a neurologist specialized in neuromuscular disease or complex cases, so there is concern about diagnosis. Involve the physiotherapist for muscle strengthening without causing fatigue. A respiratory therapist and pulmonologist may be needed if there is involvement of respiratory muscle. And we also need a nutritionist if the patient has difficulty swallowing to ensure adequate nutrition. So these are all specialties which we have to involve in the multidisciplinary approach. And don't forget, we have to treat the comorbid conditions. So given the autoimmune nature, it is crucial to screen for other autoimmune conditions that the patient might have, and we manage them accordingly. So this is how you're going to approach the patient with the myasthenia gravis. Okay, so let's talk a bit about, now we have talked about the differential diagnosis, we have taken the history, we have talked about the test. Now how we will present the case. Okay, so I put an example for you. This is just an example. You can make your own notes or whatever suits you, but remember the headings are most important, so that you don't miss anything. So first of all, you start your presentation by introduction. Good afternoon, I had the privilege of examining Mrs. Smith, a 45-year-old lady. I just put 45, 28, whatever is the age, who present with a 6-month history of progressive fatigable ptosis, particularly worse in the evening as well as difficulty swallowing. So this was your statement that and remember that the introduction with a brief statement about the patient, it will create a very, very big impact on the examiner. Then history of presenting complaint. So Mrs. Smith describes an initial onset of drooping of her left eyelid, which has progressed to involve the right side over the past 6 months. These symptoms become more pronounced as the day progresses and partially resolves with rest. She also reports intermittent double vision, which appears in the later part of the day and is alleviated by closing one eye. Over the past 3 months, she has noted difficulty swallowing, initially with solids and more recently with liquids. She denies any choking episodes. There is no associated speech difficulty, limb weakness, or sensory symptoms. She denies any associated pain, trauma, or preceding viral illness. So, whatever the patient has told you, just summarize it, and then you present in the history of presenting. And then you talk a bit about the past medical history. Mrs. Smith has a known history of hypertension for which she takes amlodipine. She has no previous surgery and has not been diagnosed with any other autoimmune condition. Briefly, we talk about the drug history. She is on amlodipine, we already mentioned, and she has no known drug allergies. She isn't on any other medication and hasn't started any new treatment recently. We'll touch on the family history. There is no known family history of neuromuscular autoimmune condition. We'll touch on the social history. She is a retired teacher, lives with her husband, and has no known exposure to toxin or recent travel history. She doesn't smoke or consume alcohol. So this is briefly when you're presenting the case. The first part should be the history. Summarize it, and then don't miss this heading: introduction, history of presenting complaint, past medical history, drug history, family, and social history. Then we'll talk about your findings, examination findings. So on examination, there is bilateral ptosis, more pronounced on the left. There is evidence of fatigable weakness as the ptosis become more pronounced after sustained upward gaze. Pupils are equal and reactive, and fundoscopy is unremarkable. Eye movements are full, but there is evidence of fatigable diplopia on lateral gaze. The rest of the cranial nerve examination is normal. Power, tone, and reflexes in the upper and lower limbs are normal. Cardiovascular, respiratory, and abdominal examinations are unremarkable. Then, after you have done your history and examination in the presentation, you talk about your impression. In summary, Mrs. Smith is presenting with fatigable ptosis, diplopia, and dysphagia, which are highly suggestive of myasthenia gravis. Then if the examiner stops you here, you stop. Otherwise, you just continue. So while myasthenia gravis is the primary differential, her presentation For given her presentation, other considerations include Lambert-Eaton myasthenic syndrome, given the fatigable nature of her symptoms, and a brainstem lesion. Although the isolated nature of symptoms without other neurological signs make this less likely. And then in your history, you'll talk about investigations. I would like to further investigate Mrs. Smith with serological testing for acetylcholine receptor antibodies and potentially the MuSK antibody. Electrophysiological tests like repetitive nerve stimulation and single fiber electromyography would also be beneficial. Additionally, a CT scan of the thorax would be valuable to exclude a thymoma. So whatever we have learned preferably, you just have to alter it according to the patient history, and then you will go on with your presentation until the examiner stops you and asks you any questions. Then you will continue with your management plan. So if diagnosed with myasthenia gravis, the patient will benefit from acetylcholine receptor inhibitors as a starting point. Immunomodulatory treatment may be considered based on the disease severity and response to initial treatment. So this is about your presentation, but normally in my experience and in discussion with the colleagues who have done their MRCP PACEs, the examiner will usually interrupt you because they don't have much time. But you should be prepared well, because some of the examiners, they might want to listen to the whole history, and if you're doing well with your history presenting complaint, your presentation, if you're doing well, then it's a high chance they will listen to your whole presentation, and then maybe in the end the time is very not much and they will ask you 2 or 3 questions. Okay, so here are some questions which I have collected from my colleagues and other candidates. What questions they normally ask in case of myasthenia gravis. So what are the classical clinical features of myasthenia gravis? So here's the model answer. So classical features include fluctuating muscle weakness that worsens with sustained activity, improves with rest. Symptoms can be purely ocular, like ptosis and diplopia, or can involve bulbar muscles leading to dysarthria and dysphagia. There can also be generalized weakness. So another question which they ask is, what is the pathophysiology behind myasthenia gravis? So this is a model answer. Myasthenia gravis is an autoimmune disorder where antibodies target the acetylcholine receptors or other components of the neuromuscular junction, leading to impaired neuromuscular transmission. And the common question is, how would you differentiate between a myasthenic crisis and a cholinergic crisis? Okay, this is a very common question actually. So myasthenic crisis, there is a model answer. A myasthenic crisis is a severe exacerbation of muscle weakness which can lead to respiratory failure. It's due to insufficient medication. A cholinergic crisis, on the other hand, is due to anticholinesterase overdose, leading to symptoms like meiosis, salivation, bradycardia, fasciculations, and respiratory depression. The hydrophonium test can help differentiate with worsening seen in cholinergic crisis. However, we're not doing the hydrophonium test anymore actually. So this is the difference between the myasthenic crisis and the cholinergic crisis. And the questions which they may ask, which drugs can exacerbate myasthenia gravis? So several drugs can exacerbate. So common ones include aminoglycosides, fluoroquinolones, beta blockers, antiarrhythmic agents, and magnesium. So remember 3 or 4 drugs which can exacerbate myasthenia gravis. What is the role of the thymus in myasthenia gravis? That the thymus is believed to play a role in pathogenesis of myasthenia gravis. Thymic hyperplasia is seen in many patients, and thymomas are present in about 10 to 15% of patients. So thymectomy can lead to improvement or remission in some patients. And the questions which they may ask, how do you manage a patient with myasthenic crisis? So myasthenic crisis, remember A, B, C, D. So immediate respiratory assessment is crucial. If there is respiratory compromise, then we have to intubate the patient. Plasmapheresis or IV immunoglobulins can be used as treatment. Anticholinesterase medication might be temporarily stopped in cases of myasthenic crisis. And finally, they may ask, what's the difference between myasthenia gravis and Lambert-Eaton myasthenic syndrome? So here's the model answer. Both are neuromuscular junction disorder, but they are different pathophysiology. Myasthenia gravis is due to antibodies against the acetylcholine receptor. while Lambert-Eaton myasthenic syndrome is due to antibodies against the presynaptic voltage gate calcium channels. So Lambert-Eaton myasthenic syndrome often have an association with small cell lung cancer, and it can present with proximal muscle weakness that improves with activity. So, my dear doctors, that's all about the presentation of the myasthenia gravis case. Hopefully, I have not missed anything. So, hopefully, it will help you. And if you want any other topic or any improvement, please just mention it in comments. And thank you very much. And I'll see you in my next presentation.